Thank you. Evening, everybody, and welcome to the Overview and Scrutiny Commission meeting this evening. I'd like to thank everybody that's attending virtually and in person. Very much, I think, in terms of our efforts this evening, it's very much a learning situation about GP surgeries, and we hope to learn quite a bit of detail that up until now we don't know, and I'm sure our questions are on behalf of our residents, who we certainly have been approached from time to frequently. So, if I may, we'll start with the agenda item 1, which is apologies for absence.
Thank you, Chairman. I've received apologies from Councillors Badebo, Mrs Mackenzie Boyle and Councillor McLean, and I understand that Councillor Gore is here as a substitute for Councillor McLean. Please also note that your Statutory Scrutiny Officer, Kevin Gibbs, is unable to join the meeting this evening as well.
Thank you, Kirsty. Are there any other apologies anybody's aware of? No? Thank you. Then we move on to item 2, declarations of interest and party whip. I don't propose to read out that whole sentence that we see every time we have an agenda. Members are well aware. Do you have any declarations of interest? No? Okay, move on to item 3, urgent items of business. I'm not aware of any.
No, Chair, I'm not aware of any. If I can just take the opportunity to say, for the purposes of the minutes and for anybody watching from home, we have 2 councillors joining us online, which is Councillors Birch and Ms Merry. Thank you.
Thank you. Item 4, which is public participation. I'm not aware of any.
Again, no, not aware of any. Thank you.
Okay. Now, item 5 is the main item on the agenda, but what I'd like to do is to jump to item 6, really because we're sitting as the Overview and Scrutiny Commission, and when we do item 5 we'll be sitting as the Strategic Health Scrutiny Committee. So first of all, item 6 on the agenda, which is the minutes of the previous meeting of the 7th of April. Are members content with those minutes?
Yeah.
Yep. And the 18th of May, the minutes of the 18th of May.
Yep.
Content? Everybody, thank you. Item 7 is our work programme update. Again, standard on the agenda, but always very interesting to hear how our panels are progressing. Councillor Porter, would you like to kick off?
Yeah.
Thank you, Chair. Sorry, Chair. A quick update on the Environment and Communities Review Panel. We have a meeting on Tuesday evening to discuss the recommendations, and we're hoping to bring the report to the Commission in July. As a result of our review we're doing at the moment, we're actually scoping out for looking at our strategic policy regarding enforcement within the borough. So that's going to be our next review as a follow-on from the integrated, because a lot of it overlapped. And then hopefully in Q4 we're going to be going back to looking at our recommendations for the registered social landlords. So hopefully all good, Chair. Happy to take any questions.
Thank you, John. Are there any questions? No. Then can I ask Councillor Birch, Mrs Birch, to update us?
Thank you, Chair. We're actually at the point of doing recommendations for the work we're doing on the review of SEND. It's taken longer than we thought because we've got more witnesses, and we're currently, last week we actually had Croydon, the Council of Croydon, present a way forward that we are going to recommend for this council to adopt. It was very powerful, the way that they found a way through some of this. So, you know, I'm really excited about it. And the officers came to the presentation as well, and I believe that that caused some excitement as well. So we're really working hard on that. We've already started to scope our next review, which was purely on county lines, but we're actually slightly changing it because during COVID, actually county lines, as you may appreciate, because people weren't moving around, because they weren't using trains, because we were in lockdown, actually the way they operated changed. So we're actually sort of slightly changing our review, and I'll bring the scope hopefully to, I think, the September meeting. It might be sooner, so thank you very much, Kirsty, but we've changed that slightly, so we're moving with things and developments that are happening. And then next year, early next year, we will actually then look at the recommendations we made for the SIL review, and we will make sure that we're evaluating how that's gone.
Thank you, Jill. Are there any questions? No? No. Councillor Gibson, please. Thank you.
I'm pleased to report that we took the final step of taking the mental health review to Health and Wellbeing Board, which means that we have ticked off recommendation number 5. Thank you to Councillor Dale Birch for making that happen. And we're setting in a meeting in about 2 weeks for the panel to get together to discuss next steps. And next week I am doing a brief review of the Blue Badge to the Disabled Access Forum on the 15th of June.
Thank you, Mike. Any questions at all? No? Thank you. Okay, this is where we change hats and we go and sit as the Strategic Health Scrutiny Committee. This is very, very similar sort of process to when we set as the Crime and Disorder Committee, when the police come and tell us about situations currently and past and forward. So I'm hoping that we will hear about past problems, how they're being solved, and I'm sure that there will be a number of questions coming forward from members. Can I just say, I know some of you will have quite a few questions. What I intend to do at the beginning is to allow 2 questions as we go round to each, and then go round so as you'll get the opportunity, but it's just so as everybody has the chance. Now, at this point as well, I would also certainly like to thank our guests this evening. Kirsty, can you just confirm who is watching us and going to educate us?
Thank you. So I understand that we have, excuse me, bear with me, so I'll just correctly pronounce this. So we have Tess Scott with us this evening, who's from Health Watch Bracknell Forest. I believe we have Fiona Slevin-Brown and Annabelle Buxton, who are representatives from the CCG.
Thank you. And thank you, each of you, for attending and coming to us. Perhaps we start then with, if we may, with Tess Scott and the Health Watch. And
Hi, I'm here.
Hi. Perhaps what we'll do is if you help us in understanding from your point of view, and then with your permission, we'd like to take questions as each speaker has spoken, because otherwise it could get quite in-depth and some would lose the track. So Tess, can I hand over to you, please? Thank you.
Can you hear me okay?
We can hear you, but are you happy to put your camera on?
Yes, of course. Sorry.
Thank you. I'm just putting your slides up for you now.
Okay, thank you.
Apologies, too many things open. Thank you. Can you see those on your screen?
I can. Thank you.
I'll go fix that. Bear with. Apologies. It's not doing what it's supposed to. Apologies for the delay.
Okay. Shall I start?
Yes, please.
Okay. So, hi, I'm Tess Scott. I'm from your local Health Watch of Brattle Forest. So basically, Health Watch, we listen and obtain the views of people about their needs and experiences from their local health and social care services. And we make these views known to the people involved in the commissioning and scrutiny of care and services. So slide 2, please. So we remain independent and impartial at all times. So basically, we did the GP Access project because we were receiving a high level of feedback from the public regarding primary care. So the Health Watch managers got together across the Southeast and we decided that we wanted to do a survey and write a report about all the findings, but we appreciated it was quite a sensitive issue and we wanted to have a measured and balanced response. So we had early discussions with the NHS and other stakeholders, and we established a regional advisory working group that were made up of key stakeholders in the primary care. So this included the CQC, GP practice managers, GPs themselves, reception staff, local authority scrutiny officers, commissioners, integrated care system communication staff, and Health Watch themselves. Next slide, please. So we hadn't really done this level of collaboration before, and the advisory group has supported the work throughout and been instrumental in developing staff and public surveys. So we basically developed 2 surveys, one which was to the public and one to the GP staff themselves. We did it across Southeast, and we had over 250 responses from the primary care staff and over 7,000 responsive from the public, which was pretty amazing, to be honest with you. Okay, next slide, please. So what did Brattle patients share? So basically, the report at the moment hasn't been published, so I'm only going to give you a snapshot and overview tonight, just for the purpose of this meeting. So we heard from patients from across 23 practices in Brattle Forest. We received over 1,000 responses for the survey, and we received 347 in Brattle Forest. The majority of respondents said that they last contacted the surgery between September and December in 2021, and 39 of those were in November. 80% stated that they were contacting the surgery on behalf of themselves. 48% of the respondents tried self-care first before contacting the surgery. Other options included on the surgery were seeking support from your family and friends, which was 15%, contacting your pharmacy first, which was 15%, and only 15 had actually tried ringing 111 or using the 111 service. So 36% of respondents felt that they had an urgent need for actually contacting their surgery. Next slide, please. So, snapshot of the themes that we were finding and hearing from and seeing from the survey results. One of the top ones was the long telephone queues. So there was a large amount of feedback regarding this, the amount of time it took to actually get through to the surgery. Many commented that they tried multiple times, they gave up. They felt really frustrated, also when they did get through, at the actual lengthy messages whilst they're on hold. Second one was the availability of consultations. So for patients registered to the surgeries that appeared only to offer on the day consultations. So by the time they'd actually got through on the by using the telephone, the allocation had gone for that day, and then they were told to call back the next day. The telephone consultations themselves, mixed feedback. Some really preferred the immediacy and the efficiency of the telephone conversations, and it was their preferred options, but others questioned the diagnostics and the effectiveness of them. Most respondents would have preferred a narrow time window when they actually get their call back rather than at AM or PM. They would have preferred it in like an hour or 2 hour window so that could fit in with their work and home situation. Online services, again, a mixed collection of responses on these. Some like the convenience of the online service, such as eConsult, and others found it frustrating and impersonal. Data occlusion was also found to be a barrier for this, especially in the elderly community that didn't really have access to internet or indeed knew how to use the eConsult system on their computer if they had one. Next slide, please. Triaging. There was a varied understanding of the pressures of the primary care and the way in which triaging system has actually been adopted and worked. Staff attitudes, while some people were sympathetic to the workload of the practice staff and GPs themselves, others were frustrated at having to explain their issues to patient advisors and receptionists during the triage process. So again, that's a triaging issue, actually understanding what it means. Positive feedback. Lots of people commented on the staff's ability and capacity to show empathy to the patients when they're dealing with their inquiries. Face-to-face consultations. There was a concern of lack of face-to-face consultations that led to an inferior service, is the theme that really resonated throughout a lot of the responses that we received. Worry that telephone consultations are not adequate or that they needed to have a face-to-face consultation that wouldn't be available. Okay, next slide, please. So further to the two surveys we produced, as I said, for the GP staff and the public, we also did a review early in December 2021. And we were commissioned by Frimley Healthcare, the ICS and the CCG to do this. So what we did, we reviewed every single GP website in Brattle Forest, and we also called up all the we also dialed all the GP surgeries as well to listen to the waiting times, telephone messages, etc. So as you can imagine, that was quite a lengthy process, but it was really interesting. The key points were for the telephone messages was we suggested a warm and welcoming message to begin with, and also removing the really long, lengthy COVID messages that were still there. The website homepage, we actually worked with Frimley and we to standardise a template for a design, because all the GP surgeries had various different designs throughout your borough, and explaining the triage explanation and the importance of actually why we triage for access into the GP surgeries. So they were the three main points that we fed back. Since then, some GP surgeries have adopted the standardised template, and we've had some really positive feedback already from patients and patients with learning disabilities, and then in accessing the new GP website. So that's been really positive. Next slide, please. So next steps, what are the next steps? The next step is actually to publish the Southeast Regional Project Report and the Brattle Forest Report as well, with all the learnings from the collaboration, and this will come out this month. We've written our report, and it's currently been given to the primary care commissioners, so they can add in any actions that they've already undertaken, and also any actions that they're going to do, and we will collate that, and that will all goes in the final report for publication. So again, we will continue to seek good examples of good practice, and we will share this all back with the ICS and local practices going forward. So that's it. So as I said, I could only give us a snapshot at the moment because the report's not published, but I hope that gives you a good overview and understanding of what we actually did and undertook.
Brilliant.
Tess, thank you for
Yes,
that. If I
that's
may,
okay.
before I
Yeah, sure.
open up to questions, there was one point you mentioned that in Brattle Forest Borough there were 23.
23 practices, yeah.
Yeah. I've got another report that says there are 10.
It's 23. It's 23 practices that patients share theirs. So on the survey, they could say which practice they were with. So not everybody did that, but people did, and it was 23 practices that we had patients that shared their experiences from.
Okay.
So it will all be on the final report, so I'm not sure where the 10 is from, I'm afraid.
Thank you. Tess, just before I understand, Fiona
Southern Brown.
wants to come in at this point.
Yeah, thank you, Chair. Just to confirm, we do have 10 practices in Bracknell. We don't have 23, so I assume that number
sorry.
covers a wider geographical.
It does.
Yes,
It
yeah.
does. I'm sorry about that. Apologies.
No problem.
Okay, thank you. Right, members, questions? Councillor Gore.
Thank you, Tess, for your presentation. It was very informative. I wanted to ask you specifically about what appears to be your mission statement, where in the beginning you said about hearing your voice and using your feedback to improve care. During your presentation, you indicated that 347 residents of Brattle Forest participated in your survey. That's out of a total practice list size of 117,530. I'm wondering how there were so few and how you go about publicising it and engaging people to hear their voice.
Well, Health Watch, we send the surveys out to all the stakeholders. We also attend various different focus groups, voluntary groups. It's posted on our website, our newsletter, all our social media, Instagram, Twitter, Facebook. Normally, unfortunately, at that time we did the survey, it was during COVID lockdown again, so we couldn't. Normally, especially for the hard to reach communities like the elderly or people with second languages or learning disabilities, we would try and do face-to-face focus groups, but at that particular time we couldn't. But we do try and reach as many people as we possibly can.
Thank you.
Jill.
Councillor Mrs Birch.
Thank you, Chair. Thank you very much for the presentation. It's really interesting and it's lovely to hear what you're doing. I was really interested in one of your findings about triage. because I think that's really something very key. You know, we hear about people going up to A&E and they inappropriately. We hear about lots of things, you know, where actually people are being directed to the wrong place. So how, you know, I noticed that you say that needs more education, more information. How is that going to come about? How are you going to actually do something about that?
Yeah, that's all on our recommendations on the report, the final report that will be published of all our recommendations. And that, as I said, has gone to primary care commissioners to add their actions and findings to that. So at the moment, I can't give an answer to it, but having gone through all the websites personally, it is an issue of actually what triage is and what people need to do. And that's triaging from the receptionist taking the phone call and why they might need to ask the patient personal information, to actually what is the process. You know, do you start with your GP first, or do you go to your community pharmacy if they can help you first? So there's all sorts of triaging questions to that, but again, that's on the final report with all the findings and recommendations that we gave.
Could I ask a second? So
That helps.
So when this report comes out, how will it be accessible to residents? How is it going to be publicised so they know these findings, and how can they actually say, oh, okay, that's what triage means? How will that actually come out?
So the report we publish on our Health Watch website, as I said, it would be on all our social media feeds. We send it to all the key stakeholders in your borough, and we ask them to filter it down.
Okay, so you actually send it out, and then you ask everybody else to cascade it out.
Yeah.
Thank you.
Thank you.
But I mean, if you want to go on to our website and subscribe to the newsletter, then you get all our regular information all the time. So that's always a good point of call.
So actually, that's something we could make people aware of more.
It'd be fantastic. Absolutely. If they subscribe to our newsletter, access the website, it's all our current relevant information is on there.
Okay, that's very good. Thank you.
Councillor Brossard?
For that, Chairman. Thank you for the presentation. Would it be possible for the PowerPoint presentation to be sent on to Kirsty? Because to be fair, I wasn't able to read all of it on the screen. So would that be possible? Is it confidential, or is that something that we can actually see?
Well, it's just an overview, just so I could give you an overview tonight, but the actual publication would be available, I think, end of next week or beginning of the following week. So that will be the full detailed report.
Fine. Chairman, a couple of points. You mentioned that you've refined the telephone message system. Is there a mechanism whereby you could actually tell the person who's rung in where they are in the queue? Because obviously if they're number 1 or number 2, they will hold on. But if they're number 20 or 25, they may feel that it's a lost cause, and therefore they may ring back later rather than wait for an hour and then be cut off. I wonder if that was something you'd looked at.
Yeah, so it was sorry, was that directed to me?
Yes, it was, Tess.
Yeah, so that was definitely part of our findings when we did the review, because obviously if you're number 25 and you haven't got time to hold on to become number 1, then yeah, all of that was recommended.
Right. If I can, just a supplementary here. Do you actually have any mechanism whereby you actually follow social media? I just wonder because, for instance, I'm thinking about We Love Sandhurst. There are some very positive comments about Sandhurst group practice and also some very negative ones. So I just wonder if social media is a mechanism that is used to measure customer satisfaction in the way that very much you talked about in the analysis you did. I only mention this because there was a meeting that took place at Eagle House School, which was attended by a lot of residents, and I think some very good feedback came out of that. And I just wonder if it's something that would be considered, extending it beyond what took place for Sandhurst group practice, maybe with other practices, to try and engage with the public in a sort of face-to-face discussion.
well, we would love to hear all feedback, positive as well is great. So any feedback would be fantastic. So you can contact myself, Tess Scott, who's East Berkshire manager, or Nick Drummond, who's your Brattle Forest officer. So Kirsty, are you able to give my email or my details?
Yeah, so as a part of the follow-up,
Yeah.
I'm more than happy to share those to the members of the
Please,
Commission.
please
Thank you.
do. Please do. And please engage with us as much as you can. I mean, this is how we learn and hear the views of everybody. So all feedback.
Thank you. Councillor Tempton?
Yes, thank you very much for that report. None of the findings were a surprise to me, because I think as councillors, most of them reflect what we've been asked many times, and comments about the contacting their GP. I'm interested though, because you've given some very definite solutions for some of them, like remove the COVID message and the standard design, and also the telephone consultations, 2-hour slots rather than AM and PM, which are impossible if you teach or in any other situation where you can't access a phone all the time. But I'm wondering if there's any recommendations about the length of the queue, and any recommendations about the availability of consultation for more than one day, or possibly better than 3 weeks ahead?
All our recommendations are put on the report, and so that's what we do. We share the views of everybody, and that information is passed on. So the length of the call obviously is a concern to a lot of people.
And did you make any suggestions, like suggesting they have a larger number of people answering the phones, or more phones, or?
That would be on the recommendations.
All right, thank you.
If possible.
Thank you. Councillor Mattock?
Thank you. First of all, can I take a liberty and explain the difference between 10 and 23 surgeries? My group, health group, actually has 3 different surgeries, and you probably get some who I only identify with one of them, and there's other surgeries in the same situation, so that will explain the difference. My first question is, there's people being quite upset because they've had tests, blood tests and all sorts of things, and they haven't been able to get a response to find out the results for a long time. Is that time element being reduced now? Or is it still continuing that there is a delay in people getting back with their results?
I can't actually comment on that. The review was just all the comments from the survey, and I can't comment on the time delays of blood tests, I'm afraid.
Another quick one, if I may. There were some surgeries which were shut, and they just had notice they were shut with no indication when they're going to reopen. Can we try to ensure that that doesn't happen again, please?
Yeah, this survey had designated questions really on there. I don't think surgeries that was closed was one of the questions on there. So this report is just the findings from the survey. But if you've got any questions like that, again, please email me and I will do my best to find out.
Thank you. Councillor Gibson?
I welcome the review. Excellent report to us. Obviously, the councillors here, we get a lot of our residents actually asking questions on this, and it's a very useful time. Just briefly, 2 things. One, you mentioned involving our scrutiny officers. So as such, will they get a copy of the report when it's published?
Yes.
Good. I thought it was an easy one. And have you got any timings for that? Because you say when it's going to come out. I mean, I know it's not in your hands, but you've got an estimation of
it's going to be this month. I would say week 3.
Brilliant.
So, yeah.
Thank you very much for the work. Excellent.
Thank you.
Thank you, Mike. Councillor Porter?
Thank you, Chair. Thank you for your presentation and report. Apart from the survey, I was quite surprised that you were unaware of like the meeting that Sandhurst Group Practice held. So apart from the survey, how do you actually engage with the surgeries to know what they're looking at doing in the future that will fit in with Health Watch? Or are you just basically patient focused?
Well, we're here to listen to the views of people that access the services, but we do have regular meetings with the CCG, ICS in regular meetings to discuss that. So we hear what's going on. If that.
But it sounds like with that forum with the Sandhurst Group Practice, you were totally unaware of it happening. So that is a group of residents getting to talk to the Sandhurst Group Practice, and hopefully that will be encouraged with other practices. So if you're meant to be engaging and listening, then surely you should know about those. So should you not be more proactive with the surgeries as well?
We are as proactive as we can, but there is one officer in Brattle Forest, so we try and reach as many people as possible.
Thank you.
We're happy to attend the meeting.
Thank you.
Thank you. Councillor Virgo?
Thank you, Mr. Chairman. Tess, I think your report is brilliant, actually, and I'd like to send congratulations to the team because I think it's very useful to us all here. One thing I'd just like to ask you, in the sense of what happens from now. I mean, you've actually made some recommendations. They seem very fair. And also, I think, as Councillor Temperton said, we're not surprised by any of them, really, because that's our experience in our inbox. But what power does Health Watch have? That would be the first question I'd ask. The second one I'd ask, if I may, in the new setup in the ICS, and it seems totally complicated and bureaucratic to me. I mean, it's just a personal view, but just trying to understand who you speak to about various things seems that you need an encyclopedia. Do you think that's partly the problem, that we've made such a complicated system, and to actually get to the grips of who can do something about these things is very difficult? Thanks.
Well, we work with the ICS and the CQC, and it's not really my place to comment on that. I mean, we work with them, we try and understand, and we feed that back to the public or help them to communicate to the public the changes. There's some a good video that's actually just come out on King's Fund, which actually explains the new structure. So again, we put that on our Health Watch website so people can actually understand the new structure of it.
But do you think do you get feedback from what you've recommended and then take that up if that's not being achieved? How does that, what's the governance of this, Tess?
Well, we take all your views and we feed those up to the commissioning bodies. So that's really our role. It is to listen and obtain the views from the people of their needs and experiences, and we feed that back.
Okay, thank you.
Thank you.
Hello.
Are there any other
Chairman.
Hello. Dale, good evening. Councillor Birch.
Thank you, Chairman. May I, first of all, thank Tess for her presentation, but can I suggest that members schedule a briefing from Health Watch on their role? Because there's probably a degree of misunderstanding or not an understanding of the full role of Health Watch. And some of the questions from Councillor Virgo may better be focused on how health partners such as GP practices, the primary care network, the clinical commissioning group, etc., respond and have a duty to respond to the Health Watch inputs. And it's probably better that members direct some of their questioning there, because it is there that the recommendations that Health Watch make have to be taken into account and shown to have been considered. So if I may, Chairman, a future meeting may wish to invite our Health Watch colleagues back so that members can understand the types and levels of consultations that they do, their Health Watch's right of access to review situations, but predominantly working off the interface of the public. And so they work from those major concerns, just like we do, just like you do, Chairman, on overview and scrutiny. As the noise level rises, so they engage. So if I may make the suggestion, with again my thanks to Tess, that an invite is extended at a later date so that members can understand the vital and important role Health Watch has, and then asking those NHS colleagues how they then are required to respond. Thank you.
Thank you, Dale. Councillor Gibson, you had a question?
I couldn't agree more with what Councillor Birch has just said. In fact, I fired off an email some moments ago before he started speaking, requesting that we might actually do that through my panel, because my panel members, I think, would benefit greatly from that sort of information. So I requested a follow-up, up to you if you want to, obviously, Chair, if you want to do it through the Commission, but it's something that I think my members of my panel would greatly value. So I appreciate what Dale's just said.
Thank you, Councillor Gibson. I think once we've seen it, I think clearly the commissioners here will want to see the report and be aware of it before we pass it to a panel for deeper thought. So, but noted.
No,
noted.
the panel for the report, yes, definitely. But I meant what Dale was talking about, actually getting the explanations of the different roles. The new roles have come on, and of course, any of the if it works that way logistically, of course, the rest of the commission is welcome to come along to that if that's the best way to set it up.
Okay, thank you. Councillor Mr. Maddock?
Thank you. Can I just change the subject? And thank you very much. It's all been so valuable. Two things going off piece, I'm afraid. One is Brant's Bridge. It doesn't. I went there one day and I found I shouldn't have been there. Oh, I was
just going to say our CCG guests are going to be speaking next.
Oh, are they? Okay, fine. And the other one was about dentists as well, because people have been dropped off list when they haven't attended for 2 years, and they're having difficulty finding dentists. I think that's
I think that's directed at as a debate.
Just flagging up.
Isabel, thank you. Tess, I think.
Can I just say on the dentist, we're hearing a lot of dentistry issues, and we're actually doing a survey in the summer. We're actually starting to look at that, because that is across the board. It's not just Brattle Forest, so that is something that we're actively already working on.
Thank you very much.
Yeah, thank you, Tess. I think we're all very grateful for your attendance and the information that you've imparted to us at the moment. We look forward to seeing the full report, and we'll read it deeply with a lot of thought with it. If I may, can we now move on, perhaps to Fiona Slevin-Brown? Fiona, thank you for joining us again. You're becoming a frequent visitor, and we're very grateful for that. So if you'd like to educate us as tested. Thank you.
Thank you, Chair. Thank you for the invitation for myself and Dr. Annabelle Buxton, who is our clinical lead and one of the primary care network leads. Annabelle's going to lead this presentation, given that the focus of discussion is primary care. So that feels an appropriate thing to do at this time. And I'm here obviously to support and provide answers to questions that Annabelle maybe isn't able to answer herself. I also just want to take the opportunity, Chair, to say thank you to colleagues. This is my last meeting. I'll be leaving the CCG in the next couple of weeks, but it's been a pleasure working with you all. And I just wanted to say thank you very much to colleagues. And then I'm going to hand over to Annabelle.
If I may then interrupt and say thank you very much on behalf of members and the council for the efforts you've put into coming to us. And I'm sure we know we've learnt a lot. So thank you very much and good luck for the future, wherever that might be.
Thank you, Chair. Off to Wiltshire.
Dr. Annabelle.
Colleagues
hello,
there, so.
welcome.
Thank you, Chair. Kirsty, I'd be grateful if you could share my slides on there, please.
Apologies, I haven't got them ready, so just I'll be a moment. Thank you.
No problem, thank you. Super, thank you. That's lovely. So next slide, please. That's lovely, thank you. So just to give you a little bit of outline in terms of how our Brattle Forest population and GP surgeries lie. As we confirmed, we've got 10 practices in the locality. We've got 3 primary care networks, so abbreviation PCN and this piece of work in that. So in the network which I belong, we've got 4 practices on there, including Sandhurst Group practice, which we touched upon earlier in the south of the patch, and Waterfield, East Hampstead and Great Hollands towards the north of the patch. We've got our Brecon colleagues with Gainsborough and Forest Health Group, and then we've got Health Triangle with Crownwood, Evergreen and our Ringmead practice. And then we have an associate member, which is our Binfield population and practice. As we alluded to, population there approaching 120,000 across those 10 practices on there. Next slide, please. So to give you a little bit of information, obviously lots of us, as well as being involved in the NHS, we're also family members and those needing to access primary care services ourselves. So we do understand the strengths and frustrations that have been borne out, particularly in pandemic times. So what we'd like to share is where we're at currently and what we're planning to do to address some of the issues that, as you rightly said, your residents have faced recently. So just to say that we are adapting rapidly to deal with demands and consequences of the COVID-19 pandemic. We obviously were at the beginning of the pandemic mandated to go to a total telephone triage model, and as such we responded to that. Services now are opening up much more. We do still obviously have COVID within our remit, and there are lots of cases of the Omicron variant currently, which does impact on workforce capacity. However, we are trying to combat that through digital transformation and obviously looking at other areas that have been impacted. We're trying to increase the demand because of the recovery and the impacts of the pandemic on our service force. But we have to note that the workforce has been under great strain, including being challenged to maintain capacity while keeping people safe, not being able to have as many people in waiting rooms, for example, as we would like because of social distancing, and obviously not being able to have COVID positive patients in the practice, along with non-COVID patients. NHS digital data shows that appointments have increased when compared to pre-pandemic levels, and we'll certainly come on to some slides later in the presentation that does bear that in effect. Patients, as we related to in the Health Watch survey, report difficulties in access in some areas on there. And therefore, we've tried, as I've already alluded to deploy and adapt technologies to respond. Overall, this has been positive, but we maintain those routes of communication with our patients to try and ensure that we are sustaining and offering a consistent offer. We need to make sure that patients are offered choice around how and when they contact primary care and ensure there is sufficient capacity to meet their needs. And that, of course, does include face-to-face consultations. The priorities at this stage, alluded to at the bottom here, include developing a consistent offer for people to access primary care, utilising all routes available to us. So that does include face-to-face, digital and telephony innovations, opening up that digital front door to embed technology to make sure that we've explored opportunities there to ensure that that first point of contact for patients is the right one and then navigated to an appropriate healthcare professional. We want to make sure that we're utilising population health information, so that's really segmenting populations and using data that exists to us to ensure that we're focusing on any inequalities that exist in our populations and being able to address those. We need to celebrate the success of the vaccination programme. So across the Waitrose site alone, there have been over 140,000 patients through the door, and I believe it's about 70,000 patients through the Birch Hill site. That, of course, is from the same workforce that delivers primary care. It's not been an additional workforce, and I think you'll agree that that has been a very successful rollout within a very short space of time. The next priority there is to secure the infrastructure requirements to deliver the PHM, so population health model of care in Brattle Forest. So as I said, that's using data to analyse any potential health inequalities and to focus on those populations to deliver consistent healthcare to them. Next slide, please. So the current position in general practice, I think this is quite helpful to reflect on where we are currently. And I think it's fair to say that Health Watch has been invaluable in their role in this as well. So we are seeing a significant increase in demand for appointments and a larger proportion of patients perhaps considering their condition to be urgent. We know in Brattle Forest that we have a largely working age population, and we know that it is this population who are asking for further contact with primary care than previously. We've noticed quite a big increase in mental health conditions across the board and increasing health anxieties following the pandemic. We know that there has been, in terms of clinical capacity, a backlog of routine chronic disease management. Obviously, patients didn't want to come through primary care necessarily during the depths of the pandemic. We've noticed an increase in heart conditions, particularly uncontrolled sort of hypertension, uncontrolled diabetes and new diabetics coming through, as well as those with respiratory conditions. We appreciate there are waiting lists to access both patients that have been referred to secondary care as they help deal with their backlogs from the COVID pandemic, and also those patients waiting for community services, which means that primary care is holding these patients with complex conditions for longer than they ordinarily would do, often on, seeing them on multiple occasions. We are, of course, looking at the backlog and looking at those patients who've been undiagnosed with illnesses in that time. And we're looking at all of our screening programmes, and that includes obviously the cancer screening programmes as well, and offering our preventative services such as immunisations, which are ongoing, obviously including our childhood and other immunisations. In terms of workforce and premise pressures, we've had an increased staff turnover due to the pressures in general practice. So we know that that's been particularly difficult across our frontline reception teams. Capacity is stretched to maximum, I think it's fair to say, across all services. And then we have had, as other areas, we've been impacted both COVID and non-COVID related sicknesses. And then we are looking at premises pressures as well, which are a longer term strategy that's being developed. Next slide, please. So our Bracknell Forest priorities. So our aims and ambitions across the next sort of year or so on there is really to ensure, as mentioned, that we want patients, when they contact primary care in that first instance, to have a positive experience. We want to stream them appropriately to pathways outside general practice if they don't need to be seen within general practice, whether that be through social prescribing, because we know that loneliness can increase medical consultations, whether that is through educating patients to self-care, using community initiatives such as the community pharmacy initiatives, etc. We want to improve access, and I think it was important in the Health Watch presentation to reduce sort of failure demand by streaming patients to that service that will best meet their needs first time round. We want to improve telephony, increase self-serve options and navigate patients appropriately. We want, where we can, because it's why we came into the job, to maintain continuity of care for patients who most need it. And by that, we mean those that have the increased complexity of need and often frailty, recognising that one size doesn't fit all, and there needs to be flexible in that approach. We appreciate that resources are not infinite, and within our gift, we have to look at how we best use the workforce that we have and developing the workforce that will be fit and sustainable for the future, offering an attractive environment where we can retain workforce. This includes the non-clinical care navigation to get those patients to the right outcome in the first place, and looking at the primary care network workforce, so the additional roles that are starting to come through, such as our pharmacists, such as our paramedic technicians, physician associates, to name a few on there. These are really invaluable resources to support care of patients with minor illnesses, but also to look not only at that reactive care, but the bigger programme of work that looks at proactive care, which can help improve population outcomes. So that includes anticipatory care, patients with long-term conditions and complex needs. As time moves on and we learn more about population health management, we want to link that further through planned care, public health and local authorities, strengthening our links with community groups and the voluntary sector. Next slide, please. So, how we've been listening to our local population. So we've obviously mentioned the Health Watch website and phone line review. So that's taken place. All websites across the patch have been redesigned. There's just a few tweaks in place to go, but they are all going live fairly shortly on there. We've also, over the last 6 months, carried out a plethora of other surveys, as you can see on there. So things such as how patients like digital access to primary care. We're often surprised that we put people into sort of age cohorts in terms of when we think they're like digital access, and often we're surprised sometimes by results. We've also looked at other things such as the same-day urgent care focus group, looking at 4 different areas on there in terms of how they would like to access same-day urgent care. So in particular, we were looking at parents, patients where English is not their first language, men aged 18 to 30, and those with long-term conditions. We've also looked across at partnership working, social listening, and our innovation fund and charities project. So we'd like to, to think that we are engaging with our local population, because their views obviously are paramount. Next slide, please. So what we've heard, so common themes that we've heard, and I think it is fair to say that people are confused by multiple entry points to primary care in the general sense, whether that's general practices, urgent care centres, walk-in centres, 111, A&E departments. And they're also confused sometimes by the variation in services, and that's where we're looking at sort of that levelling up, so to speak, on their level of care provided in different opening times. Most patients would prefer to access care through their own practices, and that at present can be a variable experience. Digital access is welcomed by the majority of users that we've had feedback from. We need to bear in mind that that is not the right fit for some on there. We need to reconnect with our neighbourhood and communities, and that through our social network, social prescribing initiatives, community and voluntary sectors is something really important on there. And I think the other aspect that we need to work on is those hard to reach communities, including making sure that materials are accessible and has a presence in our local communities on there. Next slide, please. So what are we doing in response? I'd like to think that we're doing a reasonable amount at this point. So through the winter months, through our Winter Access Fund, we increased capacity. So between November last year and April this year, nearly 9,000 additional appointments were delivered in general practices. This includes through respiratory and paediatric pathways to support same-day urgent care. We've also then, as I alluded to, had the huge amount of vaccinations delivered to our population, and we've had proactive care management through home visits on there, again for patients not able to attend our surgeries on there. Our primary care networks, who work across a number of surgeries and at scale to deliver projects, have been looking at recruiting more in terms of then clinical as well as non-clinical roles on there, so that we can make sure that we've got a workforce that is sustainable and fit for the future, and increasing capacity and population numbers we know that are coming on there. Our surgeries have been given minor improvement grants so that we can maximise the clinical space we've got on offer for people coming into practice, so that we can really look at as many people being seen in surgery as possible. We're looking at the estate strategies on there and using the information we gain from surveys to inform the future. We've been looking at the digital support to people on there and how they can access practices and their primary care population through that. And again, it is taking feedback and being flexible in the approach, I think, in terms of what works for different populations. Through self-care and alternatives to general practice, we're working together along with sort of the 111 CAS providers on there to make sure, again, that that fits in with our models of care. And we're looking at particularly cardiovascular prevention through the work streams that are going on through the primary care networks. We've continued to engage and communicate, as we've alluded to, through our residents with the different surveys and with our practice groups on there, and the lot of resources available now through the Frimley Health and Care website, particularly the Frimley Healthier Together aspect of things. We touched a little earlier on about population health management, which segments our population so that we can proactively manage those smaller groups and look at high-risk patients, for example, those who haven't been seen in the last 6 months. We've got a particular focus at the moment in terms of children and young people, and a focus on mental health between the 18 and 24 population. We're looking through the primary care networks at transforming plans to develop at-scale models and the efficiencies that those can bring. This includes, we've alluded earlier, that telephony can be problematic, so this is looking at telephone hubs with care navigators to improve access to same-day urgent care and ensuring that patients' journey is smoother through the system. Next slide, please. So this slide gives you an insight in terms of the workload that we're currently looking at on here. The two markers in the sand on there, so you've got the first vertical line on there, November 20. So that was when we entered the sort of the second COVID lockdown, and you can see that numbers were, relatively low at that stage. And then they've steadily been climbing really since April last year. So we've seen a sustained, significant increase in demand for overall appointments, but those not only on the telephone and face-to-face and other since then. And I think you'll see that that peaked in March of this year at nearly 20,000 appointments on there. So that's a huge number on there. Next slide, please. There we go. So I think this, bears it out in testament to say that, it has been a really busy time on there, but we recognise there has been a significant increase in demand and a significant increase in consultations that have been provided to our population, and that is not, reducing. It is a sustained significant increase across all areas. Next slide, please. So I think it's really important that we communicate with our population on there, and recognising that it has been a challenging time for our residents. There is a communications team within the CCG, and they have rolled out information such as that you can see on the slide on there, which is due to be launched in June of this year, really to ensure that there is consistent messaging across partners at various levels, and also to share the journey, so to speak, and influence in terms of demand and system pressures on there. There is a communication resource set up on the Frimley Health and Care website with some assets that can be downloadable as well, so we can certainly link in further with our comms team if there is interest from there. Next slide, please. So supporting staff in primary care, I've alluded a couple of times in the presentation that actually retention of staff and attracting new staff into the area is really key to both recovery and to having a sustainable professional workforce moving forwards. And we know that if we invest in our staff, that they are more engaged and they offer, they tend to go above and beyond be a happier workforce. So supporting our staff is really important, particularly given the rate of transformation within the sector. Currently, there is a 6-month engagement programme for the primary care directors and managers, supporting patient and community involvement and some practical support. We have some really valuable resources through the Frimley Training Hub and their staff on there with regular meetings, and they will highlight areas that we can support our staff with, and really looking at any weaknesses and how we can focus on those, as well as staff training and development. Next slide, please. So further information, some of these we've mentioned as we've been through the presentation on there. Certainly we've put the links on there that if those are interested, that please do spend some time, because there's some really valuable resources through there. I think that's the last slide. Thank you.
Thank you very much. Very full and got us concentrating our minds, I'm sure. Everybody will now have questions. Dr. Annabelle or Fiona is going to take the questions. Both of you? Yep, okay. Right, Councillor Virgo first.
Thank you, Mr. Chairman, and thank you, Annabelle, very much for the explanations and stuff. I suppose my first question, Annabelle, and I'm sure there's a lot of others here, and to Fiona too. Obviously, we can see from Health Watch that there is a frustration in the system, I suppose it's fair to say. And I don't want this to be a blame game, because it's not a blame game. But I think we all recognise the fact that GPs are really important in the community. And they've always been that since I was a kid. And you look up to a GP, as a person. And we want that to continue. So if there's criticism, it's because we want to protect what we had. Now, what I'm trying to grapple with in looking at all these things, Annabelle, really, is how can things really get better? Because I know we've got all these things of digital, and we've got, online appointments and telephone triage or whatever. But it seems to me either there's a shortage of doctors, which I'm pretty sure there is, and, I think you would admit, as I understand, that we depend on locums, actually, to survive, actually. Certainly that's the experience of locally and me anyway. But I can't quite grapple, Annabelle, how we're going to get out of this crisis. because, you know, a lot of the older doctors have left. We have new doctors, but some of them don't seem to be keen on the system, which they now say basically doesn't give them enough time with the patient on a face-to-face basis. So I understand what you've said. I understand the where you want to go and your thoughts about how you're going to get there. But I think people want reassurance at this point that the system that they understood in the GP was going to go back to the old way and be accessible and not have to wait 35 in a queue or not get a face-to-face or whatever. I suppose that's my basic question.
So I'm happy to start on that one. So I think we have to say you've absolutely identified the point. I think it's been in the national press a number of times that actually we don't have an increasing GP workforce. At the same time, we have a rapidly increasing population and we have increasing demand on the existing workforce on there. What we have to do, I think, is take the best of what we've learned from the pandemic in terms of the new ways of working and move away somewhat from traditional model, ensuring that we are adequately meeting the health needs of our local population. So I think we do have to embrace that perhaps the traditional model, as was, is transforming to incorporate those newer members of our primary care workforce and our additional roles that have come into practice on there. What we want to see is that patients have a better experience when they pick up that phone or they put a comment to the surgery on the first occasion. So absolutely, we would not wish patients to be number 35 in a queue, which is why the telephony hubs that are being set up, the care navigators, care coordinators, will ensure that patients' queries are answered in a really timely fashion and that they are signposted and navigated to exactly the right healthcare professional to deal with that need at the time. It may not be who they thought it would be, you know, if they had rung the surgery a few years ago. But I think for all of us, it is embracing that change and saying that we think we will be delivering a more sustainable and better offering for our population.
Fiona, did you want to say something or no? Could I just then come back on just one point before I pass this on? I hear from doctors that the system is very difficult and they get frustrated by the system. It's a lot of paperwork. It's a lot of this, it's a lot of that. And the actual time to see patients now is much reduced. I just put it to you that maybe the system needs overhaul. Maybe we need reform of this system. And the second point I'd like to ask is that at one point there was a paper, I think from the Oxford area university, who worked for the NHS, suggesting that the way forward really was to join doctors to the NHS. In other words, not have them as private practices, but have them as part of the system. And therefore it would be easier to communicate between the two and so on and so on. I wonder if you had a comment about that.
I think that's possibly a little bit beyond the remit of you know, tonight's discussion. Possibly on there, I'd love to say to you that I can overhaul the entirety of the NHS in one presentation. And I would like to think that we do work incredibly hard, particularly as we're transforming through the integrated care board. And I think the integrated part is really key, that we are strengthening our connections with both our primary care, our secondary and tertiary care colleagues, as well as those community and voluntary sectors. So absolutely, I think communication is the key. There will always be some paperwork, I'm sure, but I don't think it's detrimental to the amount of time that we spend with our patients. Paperwork, if anything, is something we take home and do later on into the evenings, and we prioritise our patient and face-to-face care during the day.
Thank you. Councillor Porter.
Thank you, Chair, and thank you for your presentation. One quick question. A question was sent to Fiona regarding how many practices there were and the number of patients and the number of doctors and what ratio. Unfortunately, we didn't get the number of doctors or what ratio. So can you give us an idea of what you would hope to be the ideal ratio for doctor to patients? and what is the ratio at present, and what are you doing to hopefully reduce that ratio so that our residents will actually get a better service from the GPs?
Who wants to take that?
Do you want me to take that, Annabelle?
I don't mind. I believe this was answered in the pack that came to you ahead of this meeting. What we look at is providing, a good service to our population, and it's not defined by an absolute percentage or figure in those terms, particularly because the workforce includes so many of the new and additional roles at this point. So the traditional benchmark is not necessarily relevant.
So there's no ratio of number of doctors to patients?
There's no. Do you want me to come in, Chair?
Yes, please.
Yeah, thank you. What I've put into the chat, Chair, and I'm not sure whether colleagues will see it, is the recently published Fuller report. So Dr. Claire Fuller has recently produced a report around primary care and the future of general practice, which I think, to Annabelle's point, really emphasises, I think, the wider primary care workforce. So primary care is no longer just GPs. There's a lot of other professionals that work in general practice, nurses, physiotherapists, pharmacists, etc., who provide, I suppose, a vital addition to that multidisciplinary team, which is so important in terms of making sure we meet the needs of our communities, which is why I think that there is an active move away from a kind of full-time equivalent per 1,000 registered population of GPs, because we're seeing some really skilled other professionals coming into the primary care workforce, who our patients actually are very, very positive about. They're very positive about, if they've got a musculoskeletal condition, that they can see a physiotherapist in their practice rather than being referred on to somewhere else. And the same if they need a medication review, they get to see a clinical pharmacist within their practice. And I think that's something that we really want to increase, I suppose, people's understanding of the benefits of that wider workforce. So Annabelle was making mention of, there's a video that's coming out very shortly, which is going to help explain to the population how the workforce has diversified over the last couple of years in a really positive way. But I would encourage colleagues to look at the Fuller report, because I think you'll find it quite interesting. Thank you, Chair.
Thank you, Fiona. Councillor Birch, wrong questions?
Yes, indeed. Thank you, Chairman. Hello, Annabelle. The mindset is where I'm coming from, and I think members and everybody in this room needs to be part of the mindset change that is going to be needed, the behaviour change that is going to be needed, because it's now time for us to help our GPs, and we can. And we can do it in a number of ways. Right?
Sorry, Dal, what's your question, please? Wrong question.
Yeah, we will do it in a number of ways. I just wanted to make the point before the question, and that is that we will not go back to how the way it used to be and what we had. And that honesty needs to be got out there, and members can be part of getting that message out there. So the question is really then very simple, and I do have a supplementary, Chairman. How can we help you?
Thank you, Councillor Birch. I think that is really helpful, and I think we would really appreciate your support, particularly I think when you're engaging with and talking to your the residents, which you are on a regular basis, I think, as colleagues have mentioned, around their inboxes and on the doorstep, having conversations, and with community groups. We would really appreciate, and we'd be very happy to accompany and support those conversations where possible, to ensure that residents really understand what we're trying to achieve here in pursuit of addressing those very concerns and issues that they are raising with you. So the concerns around getting through on the telephone, having timely access to an appointment by the most appropriate clinician, etc., etc. So we've all got the same aim, I think, and we want your support. I think that's very helpful, Councillor Birch. So yes, absolutely, we're very happy to work alongside our scrutiny colleagues with that in our minds. Thank you.
Thank you. And my supplementary, Chairman, if I may, given that there is a huge cost of what are called DNAs, that's do not attend, can we, the council, help you, the primary care network, in presenting to our residents the need to attend, or if they're not attending, to cancel as soon as they know? Can we do a joint campaign so that people, because I do notice there is now talk of, if you don't turn up, there should be a charge levied, etc. But can we work with the primary care network to support any messaging that gets people to turn up to the appointments they're given, even though, the message we've got so far is they're fighting to get an appointment?
Ironic, isn't it? In order to be, I think Fiona would share my thoughts in terms of absolutely joint working is very welcomed. Communication through all groups, getting the right messaging in a timely fashion to our residents and population is key, and we would value that joined up thinking and work.
I agree. Thank you. Thank you, Councillor. And just to add to that, I saw some data the other day. It wasn't from one of our practices, but it was not very far from here, where they had at least 10% of their nursing appointments were in essence wasted because people hadn't turned up, and we've got other people who are trying desperately to get through on the phone. So totally agree. I think that's an excellent suggestion. I think the other thing, just to add to that, Councillor Birch, is when through the conversations that Health Watch have had with the public and we ourselves have had, there were two things that have come out for us in terms of helping in encouraging our population to and supporting them in understanding where to go. One was the lack of understanding of what's available in your community pharmacist, that actually people still perceive the community pharmacist to be somewhere where I'll get charged, possibly because of picking up prescriptions, etc. But actually there's a lot of free provision in your community pharmacy that is commissioned by the NHS. So, I think we need to promote the role of community pharmacists. And the other one is 111 online. So the online version, I know people will have said to us it's difficult to get through on the phone to 111 on 111 sometimes, but there's a very good online version of 111, which again will help direct people to a lot of very sensible advice and support, as well as obviously our Friendly Healthier Together, which is very much parent focused and is excellent. It's got excellent resources. So yes, thank you very much for that suggestion, Councillor Birch, very helpful.
Councillor Brossard.
Sorry, thank you for that. A couple of questions that I've got, maybe of Annabel. The Health Secretary is advocating Saturday openings of surgeries for face-to-face appointments. It's something I read in the press. Is this something that would have merit within Bracknell, or is it something that is shall we say, the subject of negotiation, if I can use it that way?
Absolutely. Thank you for your question. So there have been Saturday appointments and Sunday appointments available in Bracknell for a number of years now through our extended hours offering that operates from Boundary House Surgery. You'll hear that there is a new primary care network enhanced access service, and so that is being tweaked a little bit, but absolutely there is service provision from that. It changes slightly later this year in October, but absolutely there is an appetite for not only GP appointments through that, but obviously trying to reach some of our harder to reach population, so that working age population that can't come to appointments during the week, trying to make sure there's provision for smear tests, for screening, for blood tests, blood pressure checks, etc. So looking at those other resources, including phlebotomy, healthcare assistance and nursing appointments as well. So absolutely, we welcome that very much.
Thank you. As a supplementary, if I can, Chairman, very briefly. Closer to home for you, Annabelle, given that you're responsible for 4 surgeries, which are listed on page 2. I'm aware that, for instance, with Santa's group practice, 2 of the doctors there have moved away, apparently, to be nearer home. What are the process, and I think Councillor Virgo asked part of that question, what would be the process for recruiting 2 new doctors, or maybe more than 2, given that there's currently a shortage, I believe I understand?
Absolutely. So our GP practices operate as independent entities. They have practice managers and aligned professionals that will help them to draw up job specifications in terms of what they're looking for, and they have various routes through which they will advertise for further staff, as they would do if it was a nurse or a healthcare professional or a member of the non-clinical team. So they will be recruiting where available through word of mouth, through publications, etc. So there are various routes available through them.
Councillor Gore and then Councillor Mrs Birch.
Thank you, Annabelle. I wanted to just talk about focusing on inequalities and addressing them, something you mentioned when you were speaking. So dealing with older people, many older people struggle with technology, and I know the Older People's New Opportunities Forum have helped over 350 people become digitally enabled. So, but in Brattle Forest, there's over 16,000 older people, and referring to Councillor Birch's, the way we used to be and what we had is not going to happen anymore. How can we accelerate provision for older people? Because these are the people that will be heading to A&E when they can't access treatment or someone to speak to.
Absolutely, and I think that's a really interesting point on there. As I said, we've been surprised sometimes when we've looked at age groups in terms of, we assume that all young people want digital. They don't. And we assume that all older people don't want digital. Again, not always the case on there. So I think sometimes it's challenging our own perceptions from that aspect. But I think it is also approaching things with a one size most certainly doesn't fit all, which is why we cannot go to a wholly digital solution. We need to bear in mind that actually there will always be a role for picking up the phone and speaking to one of the practice team. There will always be a role for us being able to segment our populations to be able to alert to the fact that some have more complex needs. And we have segmented our populations to be able to identify those individuals that need a different offering. Our working age population who don't have any long-term conditions tend to be able to see any of the additional roles from there, but we are recognising that we need to be able to prioritise our valuable, GP resource to be able to look after exactly that patient group, and to be able to say that absolutely they need to be able to have a really good relationship of continuity with their, primary care providers.
Thank you. Could I have a supplementary, please? Just in terms of a question that was raised earlier and relating to this, I understand what you're saying and I agree with you. It appears that there are 1,612 fewer qualified full-time GPs at the moment, and I'm wondering how you're going to equate your ambitions and your plans with the fact that there is such a dearth of GPs in the system. I mean, what are the plans to make up for the shortfall, or are your plans over ambitious?
I think in response to that, as I mentioned, we like to look after our workforce and those teams. A lot of practices in the locality are training practices, so they train GP registrars coming through. We're generally very successful in retaining that population of young GPs, particularly when we offer them to be mentored by more experienced GPs. When we look at their continual professional development, for example, we need to provide that sustainable and attractive environment to them so that they do stay with us. So really looking after our own is key, and nurturing our relationships within the system to make Bracknell an attractive place to come and work. We recognise, though, that to support our ambition, we do need to embrace the changes that we have started with in terms of working at scale and the efficiencies and economies of scale that come with that, and embracing the new workforce, as Fiona alluded to, in terms of our pharmacists, our physician associates, our paramedics, and all those allied health professionals.
Chair, do you mind if I was just going to add to that, if that's okay?
Sure.
Yeah, thank you. It was really, I think, just as well to emphasise the point that the changes that we're making in terms of the model are very much around making this a really attractive place to come to work in, because what we're finding, I think rightly, is that home work-life balance is really important. How people are treated and looking after their well-being, our workforce and our GPs are no different, and colleagues will have heard of some of the abuse that frontline staff are in receipt of, both reception and clinical staff. So it's really important to us that we work as hard as we can to develop those innovative models that make this a really attractive place to come to work, and that we create the conditions, working with our communities and with colleagues like yourselves, where our communities are part of the solution and working with us, because I think that will attract new staff to want to come and work in this area, in addition to what Annabelle's just described in terms of the work that we do with our practices, our training practices, and overall we've been quite successful in many of our practices in recruiting to vacant posts. But it is a task. If I'm honest, there are less GPs than there are jobs for GPs at the moment. So, you know, we know we've got our work cut out for us. But I think Bracknell as a place is a nice place to live, and the surrounding areas. So, you know, there's no reason why, if we're able to deliver the model that we want to, that we shouldn't be able to attract high quality clinicians who want to come and work in this area.
Thank you. Councillor Mrs Birch.
Thank you, Chair, and thank you, Annabelle. I'm going to actually ask you a few specific things, if I may, because I've had complaints that somebody couldn't have a blood test at their GP. Do all GPs do blood tests, or are they now sending them to the hospitals?
I think each GP practice will vary at present in terms of whether they employ somebody specifically to do blood tests. So I think we would want to take that specific query away and have a look perhaps from that perspective. So more than happy to take that one away to have a look at for you.
Thank you. And also something that one of the other members mentioned, things sometimes don't seem to be joined up. I have a resident who, fortunately, you know, I'm giving nothing away. She had breast cancer. So what happened is that she has a mammogram. So she had a mammogram and nothing came back. But the day after she thought that she should hear something, she had a letter saying, "You've missed an appointment." And she was extremely upset and obviously contacted me. And then she phoned up because I advised her to phone up. And she was supposed to go and see a specialist, but somehow they hadn't sent the letter and it wasn't joined up. Her GP hadn't alerted her either. And yet she still hadn't had the results from the mammogram. And then they wouldn't give her the results over the phone, the GP wouldn't. And it was not joined up at all. Eventually she did go and see this consultant, and actually the mammogram was fine. But the anxiety, in the end she had 3 letters. And she was concerned that as she'd missed an appointment through no fault of her own, because she hadn't been notified, that she would be put on some sort of blacklist and she wouldn't be able to go again. And, you know, of an elderly person, it was a real anxiety. So
Absolutely.
I'm feeding back that really it needs to be joined up, because
Absolutely.
it causes great concern and anxiety.
Absolutely.
So I am very concerned that things aren't joined up at the moment.
Yeah, absolutely. And from that example, I think we can all empathise, can't we, in terms of how anxiety-provoking that would. I would suggest, again, obviously, I don't know the details of that individual case, and that may be one where PALS, the Patient Advisory Liaison Service, might be able to provide a little bit of scrutiny in terms of that element of things.
I have advised that, but I'm just saying that it does seem to me that phoning up the surgery, she got no answers at all.
I can't comment because I don't know what information the GP surgery, if any, would have had at that point in time. So from an isolated, incident, I can't comment that, services are not joined up, but I would suggest that absolutely we would like to take each individual case seriously, and I think PALS would be the right avenue on this occasion.
Thank you. Do you have any statistics about the number of people who are actually dealt with successfully with a telephone and don't need a face-to-face visit? Do you have any figures on that?
I don't have absolute figures at this point in time. I think we would say that if our clinicians felt that a face-to-face appointment was warranted following a telephone consultation, that's absolutely what they would arrange from there. But in terms of percentages, no, I don't have those figures, I'm afraid.
Thank you. So this model is actually going to continue, you think, and it's going to get embedded, where it will be telephone consultations rather than face-to-face?
I think at present there is a wide variety of appointments. There are, the figures show that a lot of appointments, in terms of it's more than 50% of appointments, are in fact offered face-to-face. So there is a hybrid model of both telephone, digital and face-to-face appointments on there, and it will be that we look at what is looking after our population in the best and the most efficient way, but we will always keep patient care, and that being good quality clinical care, at the forefront of our ambition.
Thank you.
Councillor Templeton.
Thank you very much both for all this. I'm going to talk on behalf of some older people that I represent and have had issues. In our local surgery, you cannot go into the surgery and make a face-to-face appointment. You have to do it on the phone. And I know some of the people have been there, number 32 in the queue, and they have never got through and they've given up. Now that person was worried because she thought she needed to see a doctor, and she just gave up. That was it, finished. It was too much. So I'd like you to answer that, but I'd also like to ask another question. Perhaps you could answer that first.
Clarify what the question is from that perspective.
My question is, does everybody have to go on the phone? And if she can't cope with digital, it's no longer use asking her to go online. She can't, and if you go on the phone, you're in a huge queue. And so if you give up, she wanted to go face to face and was told, she walked into the receptionist and was told, you cannot book an appointment here. You have to do it online. So she gave up. How can you help someone like that?
Councillor Templeton, if I could come in, I'd be really grateful if you could share the details of that GP practice with us. We should be offering the facility for people to walk into their GP practice, as Annabelle's described, recognising that not everybody has got access through a telephone, and we might assume they do, they don't always, and they certainly don't all have access to digital technology. So that facility should be available in all our practices for people exactly as you've described. So I'd be very interested to know which practice in our area that was, and we will pick that up with them directly. So feel free to contact me directly with that.
Thank you. My other question is another problem, is that you said you commission pharmacists. Now, do you commission the times, or NHS commissions pharmacists, do they commission the times when those pharmacists are open? Because we have a real issue when a notice goes on a pharmacist saying shut temporarily. It doesn't say for 10 minutes, it doesn't say for 2 hours, it doesn't say until further next week. And people I know have walked a long way to get there and have made a lot of effort, and they're absolutely devastated because they need their medication and they don't know whether to wait around or actually then to phone me and say, where can I get my medication? And I haven't a clue. So can you please, what happens? Yeah. Do you actually commission, and what do you do? I mean, I have written in and complained about this to the NHS, but what happens when the pharmacists just change their hours?
Yes, yeah, no, absolutely, Mary. So we have had some situations recently, I know, where some pharmacies have closed because they haven't got any pharmacists on site at very short notice. So NHS England currently commission community pharmacists for the core contract. That is changing in July. So that will move to the ICB. So we'll be accountable for commissioning local community pharmacist services. What the CCG commissions at the moment is enhanced services from our community pharmacists. So, for example, we've got a community pharmacy prescribing scheme, we've got a hypertension scheme that we're commissioning, and we've got a UTI scheme that we're also commissioning from our local community pharmacists, alongside some other enhanced services. So to your point about I suppose consistency and of opening, etc., I will be very happy to take that up, Mary. Obviously, it's transitions towards the ICB taking that responsibility on board. As it stands at the moment, when that does happen, we contact NHS England ourselves as well to ask them to raise that with that particular provider, and they do. They will pick it up because there's a contractual obligation to be open certain times and to have pharmacists on site in the same way as there is for GPs, and they have a core contract. But I'm very happy to pass it on to my colleagues back at the ICB as well. Thank you.
Thank you.
Councillor Virgo?
Could I just go back to what Councillor Birch said, actually, because I think it, as far as I understand, I think the GP surgeons do a very good job on this one, actually, to be honest with you, because whenever I've gone to an appointment, I get a text the day before, and I think I get a reminder saying, if you can't do this appointment, please contact so-and-so. I can't see what else you can do, to be honest with you. So I would say that system works extremely well. Could I just ask one of Annabelle, actually, because I hear that a lot of the surgeries are people going on a constant basis. I think it's called in the trade walking well. I might be wrong. I wondered what your thoughts were about that. Going back to what Mrs. Birch said, is there a triage that would stop that? How can we, I'm just wondering if the demand could be limited to those people who definitely need a doctor rather than those that probably could be pushed to a pharmacist or...
Absolutely. I think that's a really interesting thought actually on there. So when we've looked at our population health sort of segmentation, we've looked at our amber and red, so sort of RAG rated. So we've looked at amber and red populations that have increased complexities such as frailty, age, long-term conditions, etc. And we try and prioritise those where we can in terms of our GP access. We then have our green segment, which is by in a way the largest segment of that population. I think it's, off the top of my head, it's about 65%. I think, Fiona, correct me if I'm wrong. And that tends to be our well, younger, working age population. And absolutely, as we introduce the telephony hubs and the care coordination and navigation, we can make sure that that population could see one of our pharmacists or physician associates or, another avenue through paramedics, etc., for their care need. And obviously that can then be escalated through a GP if necessary, but there are lots of other avenues available to that. So what we're trying to do is work smarter with the workforce we've got, but trying to deliver better outcomes at the same time for our population.
And would that, sorry, just supplement, would that actually be through the receptionist that would suggest perhaps you should go to a pharmacist to sort it out? How would that work in practice?
So it will look at whether the patient, thinks that their need is of an urgent nature or not, and absolutely it will be a combination through our practice reception teams and through our telephony teams and that more complex care navigation piece of work. So it will be a combination of making sure that everybody is, using those tools available to them.
And in some practices you have a pharmacist as well, a paramedic as well, don't you?
Yes, yeah.
Which helps that situation?
Yes.
Okay.
So some practices will employ their own paramedics, and then there are paramedics available through the primary care networks as well, so they can deliver both obviously home visiting services, reaching those populations not able to come to the practice, but also looking at that minor injury and minor illness element of same-day urgent care.
Yeah, thanks very much.
Thank you.
Members, any other questions? No? And
Thank you.
can I thank you both very much for coming along this evening and giving us your time and the education probably that we've got, and hopefully you may have got a little bit as well from us on behalf of our residents. So I'm sure you clearly in the papers are aware of a lot of them, but it's really, I just feel personally that you're aware, everybody's aware, but I'm not quite sure who's got the actual clout to make something change. It's, if I can give one example, it seems to me a lot of the local surgeries, for instance, do not do ear syringing now. And so people are forced to go private. And I'm beginning to wonder whether that is actually a trend that we're going to see in this area. Have you had any thoughts on that?
I don't have any particular thoughts in terms of ear syringing. I think it is a question of it has been looked at in terms of which services are priority and provide the best patient outcomes and care, and it was felt that there were better alternatives to sort of ear syringing necessarily in terms of outcomes.
Okay, well, we'll leave it there. I've got no more questions. Again, thank you both very much and good evening.
Thank you, Chair. Goodbye.
Thank you very much. Good luck, Fiona, too.
Yeah. Tess, if I understand you're still on the call as well, so I hope you found it interesting. And again,
I did, thank you.
For your efforts to us this evening. Another big thank you from us all. Thank you. Ladies and gentlemen, members, I think that concludes this evening. I hope you found it interesting. We've all been a little wiser now. If not, perhaps even gone away with a lot more questions than we came with. But that's what these overview and scrutiny type meetings are for. And we'll meet again as the, not the crime and disorder, whatever it is, the security, what do we call this one? Yeah, Strategic Health Scrutiny Committee. That's very posh. Okay, can I wish you all a good evening and thank you all very much.
Thank you very much. Thank you.